Hello, everyone, and welcome to today's webinar with the title Genitourinary Syndrome of Menopause, Guidelines, Clinical Insights, and Real-World Practice. I am Angelica Hirschberg, and I'm gynecologist and professor at Karolinska in Stockholm, Sweden, and I am the past president of EMAS. And today I have the pleasure to be the chair of this webinar and will present the speakers. And the first speaker is Professor Ludwig Kiesel. He's a senior professor and past chair of the Department of OBGYN at the University of Münster, Germany. And he's the present Secretary General of EMAS and past president of the German Menopause Society. And the title of your presentation is Guideline Perspectives on Local Therapy, the Role of Vaginal Estrogens. And before you start, I would like to remind all the audience that you can ask questions, and please use the Q&A function for this. So please, Ludwig.
Well, thanks, Angelica, for the introduction. And I think we have to thank EMAS to spending so much effort into the webinars, into an important topic, which is very important for many women. So you have probably visited some of the previous webinars, and today we are going to focus on the guideline perspectives on local therapy in my talk, and especially on the role of vaginal estrogens. So the guidelines which are relevant will be listed today. First of all, my disclosures. I have been involved and also leader of some of the guidelines relevant to the topic, and that's in menopause in Germany and in Europe, and the other topics as you've seen, and I'm also in some of the boards of scientific societies. If we are involved in this topic, we have to be aware that the GSM, which you have already heard quite a bit, which is the genitourinary syndrome of menopause, is also a new terminology, which includes vaginal atrophy, but also others. But first of all, as you can see on this slide, estrogen deficiency will obviously result in changes of vagina and also vulvar changes. And this has been the old term, vaginal atrophy. And this slide shows you that some of the symptoms during menopause will occur at different time intervals from this onset of menopause than others. So vaginal atrophy is quite soon. Maybe vasomotor symptoms are earlier, but other signs and symptoms can occur later. So on the right, you can see that, of course, vaginal atrophy, and now the new term GSM, is a part of the whole range of topics and problems. So you can see that all the different complaints and symptoms what women have. So you have to actually include this in your discussion and to see what's more important. So if you look at the guidelines in the literature, you can see a whole range of topics which either include GSM in the guideline discussion or are focusing entirely on that topic. You can see on the left, there are quite a few guidelines from different societies, and EMAS, publishing in Maturitas, is shown on the right. So you can see different topics all around menopause, but also today's topic, which is the topical estrogens. And this is all in this journal. So you can look it up and you can get additional information. So obviously today I won't be able to cover everything, but I will pick the important issues which are covered by individual ones. And I will start first with one of them, which is here on the left, is the genitourinary syndrome of menopause. So it's focusing entirely on that topic by a special society. And this is what is the main message of that society's recommendations. Well, first of all, the signs which are obviously seen when you examine patients are listed here. And in the next lecture, you will hear the practical approaches to that, but also the symptoms which patient may or may not tell you. So it's important to ask about some of them. And all this may end up in certain symptoms like sexual pain and dyspareunia. So it will actually add up sometimes in a different symptomology. Now, if you look at the guideline suggestions, you will have recommendations which have very different quality of evidence and also grades which are marked by certain signs. So here on the left, you can see if the evidence is very high, so if there are good studies and good data, this is how it is marked. And if it decreases in quality and also in the grades, you can see it's very low. So the grades are actually shown here, A to D. And if you see GPP, that means it's just a recommendation of best practice. So this is what all the experts have experienced, but it's often not really well regarded because it is not underlined by good studies in evidence like RCTs, etc. Some of them are very difficult to do RCTs on. So you will see that all along, as I show you here. So IMS is the abbreviation of the International Menopause Society, which encompasses the global society for, so that may be relevant for everybody globally. So first of all, this society tells you about definition and screening. So it says that one should be aware that vulvovaginal atrophy and genitourinary menopause are not identical because GSM includes a wider range of signs and symptoms that may have different causes. So GSM is very common. Clinical presentation may be variable and may have big impact on quality of life. So it is really important. And I think the last point is important. You have to be proactive in screening and diagnosis. So you actually have to look for it and you have to ask questions. So that's very important if you're dealing with patients in menopause. Now, next comes when should you treat? So what are the indications for treatment? So the same society, IMS, has listed a whole range. So of course, it should be individualized as considering evidence-based data as long there is something. And of course, one should treat symptomatic GSM in order to improve quality of life and intimate relationships. So this, for example, has a very high grading and also high evidence. And so it goes on with other things they remark that GSM is actually a chronic condition. So it does not resolve without treatment and may return if you discontinue therapy. That's something very important. So therefore, long-term treatment is often required as symptoms can occur on cessation of therapy. So how does it really look like? So on the right, you can see the difference between epidermal and below that, the vaginal, stratum corneal. And these are, of course, if you would biopsy it, you could see that. So what happens is you have, of course, the responsive element is actually the estrogen receptors, and there is, of course, a high affinity of the estrogen we could actually use. So low-dose vaginal hormonotherapy is something which would act via these receptors and make the relevant changes. And the changes which are here listed are quite well-known changes we would like to have on therapy with vaginal hormones. So if you look at the guideline, what does IMS say about vaginal estrogen therapy? So it says that healthcare providers should offer vaginal estrogen therapy to improve genitourinary and sexual symptoms associated with menopause. So that's has a very high evidence to say that. And they should add vaginal estrogen therapy if GSM symptoms persist when using MHT. So that's quite common that MHT sometimes is not quite sufficient. So the last point is to stress the use of vaginal lubricants and moisturizers and to women with symptoms of vaginal dryness and dyspareunia. And this can be used either alone or in combination with vaginal estrogens. Now, every 2 years, there is a major world congress in order to revise and maybe to reinstate that. And we have written a paper, so you can look that up, just the important issues on many things, also on GSM. So basically, IMS recommendation has been reconfirmed here that local estrogen therapy is an effective mean of treating genitourinary syndrome and symptoms, including in women with POI. So vaginal estrogen therapy alleviates all the symptoms and signs I've shown you before, and it has there's a lot of evidence now to demonstrate long-term endometrial safety. Now, there is a lot of discussion about laser therapy, so it has been suggested to improve vaginal symptoms, but the evidence is somewhat contradictory, and it should be actually mostly limited in research settings in order to get good data if it's useful. So this is not something which is taken up as a main recommendation. So there is another well-known NICE guideline which takes a position on vaginal laser treatment. So it clearly suggests, NICE from the UK from 2024, it suggests do not offer vaginal laser treatment for GSM with menopause unless as part of randomized controlled trial. So that's here. And if you want to look it up in full detail, you can see here the link to that statement. So if you are in North America, of course, you are interested mostly on the position statement of the North American Menopause Society, which is called now the Menopause Society. So it also states that GSM is likely underdiagnosed and undertreated. So it's something very important for healthcare providers to understand. So it is important to know the symptoms in order to effectively manage it. And there are many prescribed and non-prescribed drugs to use. So in those years, 2020, it was still unclear about the long-term safety, but I just mentioned in other guidelines, it has been stated that they are already proven to be safe. So other things like laser is not quite clear if there are enough data to give recommendation. And this is about the same said in other guidelines. Now, many women ask about hormones in general and safety of these hormones, and they are sometimes, if not often, referring to breast safety, because there has been a lot of discussion, as you all know, and it's interesting to know that breast safety is supported by a really big meta-analysis worldwide on the epidemiological evidence, which includes more than 500,000 women in a collaborative group to demonstrate safety in those women. Because due to medication in breast cancer patients, symptoms can even be more pronounced than women without breast cancer. So this is suggested to use either very low dose or ultra low dose estrogens in those patients, what is in general in this meta-analysis. And if you look at patients who are survivors of breast cancer, they're all afraid of recurrence. But if you look at the use of vaginal estrogens and controls in a study which has been published 3 years ago, and looking at how much difference there is, and basically there is none. So the use of vaginal estrogen does not increase the likelihood of recurrence. So that's very reassuring. And another, just very recent survey points in the same direction and has been published in Maturitas this year. And you can see here the main issues. So vaginal estrogen is actually absorbed just to a very minor degree. So there is no demonstrated increase in the incidence of breast cancer or its recurrence or mortality from breast cancer. So this is something very important because it can be used even in women who are on aromatase inhibitors, which is quite common. So unfortunately, there are no good head-to-head comparisons in many settings. So some of the questions can't be really answered in full detail. So when you look at, again, at the International Menopause Society, IMS, about the treatment of GSM, it is recommended by the society to see and review women with GSM annually, or when it's clinically needed, of course, which if symptoms change. However, there is no really full-blown evidence for that. So it's a recommendation, but there is no good study to demonstrate in detail. And therefore, it's important to discuss different products. There may be new ones coming along. So that is something important to see them again. And often in some countries, testosterone is discussed to use in addition, but unfortunately, there's a lack of data on systemic and vaginal testosterone for the treatment of GSM. And this is also GPP of IMS recommendation. So my final slides actually summarizes for you the essential points which can be looked and seen if you are reading these guidelines. So GSM is regarded as very common, but often undertreated. It's a chronic condition caused primarily by estrogen deficiency, and it will affect vulva, vagina, urethra, and bladder. So vaginal estrogen therapy is considered a first-line treatment for moderate and severe GSM symptoms when non-hormonal moisturizers and lubricants are insufficient, which are often used by patients anyhow. However, what's important is adherence. Patient has to be reminded that only if they use vaginal estrogen, the effect will come, and it will decline the effect if they don't adhere. So adherence should be supported. Local vaginal estrogens are effective in improving symptoms, including vaginal dryness, etc., including bladder problems. So available vaginal estrogen have various formulations and should be individualized according to patient's preference. The low-dose vaginal estrogen therapy generally does not require concurrent progesterone treatment. A common question. Normally, you would, in systemic treatment with oral treatment, you use progestins, but this is not really regarded as essential because even with intact uterus, its systemic absorption is minimal. So current evidence actually suggests that low-dose vaginal estrogens have a favorable safety profile and are associated with minimal systemic endocrine effects and can be therefore taken as an important treatment modality in women suffering from GSM. So thanks very much for listening to my talk, and I will hand over and glad to answer your questions later on.
Thank you very much, Professor Kiesel. So we will wait with questions until the end of the webinar. So now, and I encourage you again to please submit questions, and there are several questions coming, very, very good. So now we proceed with the next speaker, Professor Santiago Palacios, who is the founder of Palacios Clinic at sorry, Madrid?
Madrid.
Of course, Madrid in Spain.
Well, no. Now we have Madrid, Malaga, Galicia. Now we have 4 clinics.
Oh, excellent. Very good. Anyway, and you are also a board member of the International Menopause Society. And the title for your presentation today is Clinical Experience and Real-World Evidence with Vaginal Estrogens in GSM. Please, Professor Palacios.
I'm going to do it. Sorry. Okay, thank you very much. I am so happy to be here with our good friends as Angelica and Ludwig are. In my thought, I think that this is going to be a summary of all the presentation done during these last couple of months in relation with GSM. But of course, this is a final conclusion to speak about the real world practice. I'm going to try to translate the Ludwig presentation, fantastic presentation, in the real world practice, that this is not very easy. I'm going to try to go slowly. What are my objectives today? Is first understand the real world border of GSM, then recognize barriers to diagnosis and treatment. We have so many. Apply individualized therapeutic strategies. We have a lot of different possibilities, and we need to decide what to choose. Apply individualized therapeutic strategies, I said, improve long-term adherence. Probably the adherence in the real world could be one of the major problems that we have now, and integrate evidence with patient-centered care. Perhaps, as Ludwig said, if I will try to define what are our problems, the real world problems with the GSM, is that this is a chronic condition, but at the same time progressive. That means here how important is an early diagnosis and early treatment. Is underdiagnosis, as I said, and undertreated. We need to understand why. Why is underdiagnosis and why is undertreated? To understand this, perhaps we can improve. As my colleague said before, we are speaking about one disorder that suffer more than 50% of our patients after menopause. But this is not the most important issue, it's the consequences. What are the real consequences? They are going to affect the sexual relationship, the self-esteem, sleep, of course, physical activities, everything, and the quality of life. That means that the consequences of this syndrome, they're going to be fundamental. And I try in the last sentence to say, many women normalize symptoms as part of aging. No, please. If we can avoid, we need to avoid. This exactly is the issue of this presentation. Of course, we understand that this GSM is a silent epidemic. It's like the iceberg. And why women do not consult? There are so many reasons you can read here. Lack of information, fear of hormones, cultural taboos, that there are so many, depend of the culture, or depend of the country, and believe that this is something that is in relation with information, that symptoms are inevitable. But on the other part, the doctors, we have several problems too. The time could be one of the fundamental. The time constraints, lack of training, and this is exactly the reason for having this kind of webinars. Focus more in some other areas, vasomotor symptoms, breast cancer. And we need to put attention, not only in this area. And for this, probably we need to speak about the sexuality. The question is that if we do not ask, patients rarely tell. This is the reason of the silent epidemic. Well, you know very well everything in relation with the pathophysiology in clinical practice, how important are the estrogens, and when the estrogen decline, well, you know that they increase the thickening epithelium, the glycogen is going down, the pH is going up, the elasticity is reduced and reduce it to the vascularization. But the point for me is not all of these things, are the consequences. The consequences are inflammation, tissue fragility, sexual pain, and urinary dysfunction, but this is one major issue, and recurrent infections. In the real world, the consequences of the GSM, they are enormous. This is the reality. And we are going to emphasize some areas. For example, the lower urinary tract effects. When you have a patient after menopause with urinary effects, problems, or disorders, or symptoms, you need to think about the GSM. If the women they suffer of the urgency, frequency, nocturia, dysuria, or infections, recurring infections, think about the GSM. And of course, you can trade as a GSM at the same time that you are going to maybe to prescribe some other things. But always to trade the GSM, you are going to improve the lower urinary tract symptoms. Well, need to remember that in the vagina there are so many estrogen receptors, but in the urethra too, in the bladder too, in the muscles, in the pelvic floor too. That means that local estrogen works everywhere. I say that this is true, that many patients initially consult with this problem the urologist or primary care physician rather than gynecologist. My only conclusion here is when you have a patient that are in the postmenopausal years with urinary symptoms, please think about in GSM. Exactly the same with the sexual consequences. If you have a woman with dyspareunia that start after menopause, of course, you need to think about GSM too. Always they start with dyspareunia and then with loss of desire. Of course, if you have dyspareunia, you decrease the desire. This is so important to try to speak about sexuality. I know that we have no time, blah, blah, but we need to understand that probably if you speak about the sexuality, you are going to start making an early diagnosis about GSM. This is the point. The diagnosis is absolutely simple. Probably this is the disorder most simple that the gynecologists we have in our hands, or the GPs. The history, the symptoms, and the physical examination. With all of these three issues, absolutely cheaper, you can make a good diagnosis. In the examination, you can find the pale epithelium, the loss of rugae, friability, elevate pH if you like, but well, it's history, symptoms, and physical examination. Very simple. If you have some doubts, of course, you can make a biopsy, etc. But well, to make a diagnosis about GSM with this history, symptoms, and physical examination is enough. Perhaps for me, this is the key. The early training. If you start making an early training, you are going to avoid to have moderate or severe symptoms. If you do an early treatment, you are going to avoid the tissue fibrosis, to increase the severity of the dyspareunia, the sexual avoidance, the worse adherence, etc. Early interventions are or is fundamental for everything and for the improve the quality of life. We know that it's a chronic and progressive disorders. For this, we need to start as soon as possible with the treatment. In relation with the real world and the treatments that we have in our hands, we have so many, and this is something that this is very conflicted because we are thinking about what exactly treatment I am going to recommend. We have a lot of different moisturizers, and better. This is true. We have lubricants. Well, all of these measures like regular sexual activity, they are important on the pelvic floor therapy, and lifestyle measures, they are important too. But when we are speaking about non-hormonal strategies, we need to think about that all of these strategies improve symptoms, but do not reverse atrophic change. This is to be only in the 50% of the problems, but you are not going to complete exactly the strategy for a good treatment. What is the point? You can prescribe, as Ludwig said, at the same time with other treatment, of course. You can prescribe local estrogen plus lubricant, for example, or in occasion you can do a mixed treatment, you can do it. But you need to understand that with this treatment, we are not going to reverse the atrophic changes. Other point is what kind of vaginal estrogen therapy we can prescribe. We have tablets, we have creams, we have gels, we have rings. Well, we have ovals. You can prescribe as you like, because all of them in the meta-analysis show that they are effective. That means that what is depend on the women preferences. You can prescribe one or the other. We have clear with the meta-analysis there are good clinical benefits, and we only the sentence that Ludwig said exactly the low doses of local estrogens are the gold standard of GSM training. No doubt. Some brief notes on estriol. Why? Because I remember Professor Di Falucci with this beautiful paper that about the early history of estriol, because estriol is very well used, and this is one of the most usual local estrogen that we have beautiful real-world perspective with vulvovaginal symptoms, early GSM, sensitive patient, and long-term local therapies. But again, you need to individualize and to speak with the patient what are the preferences in relation with the local estrogens. But Professor Kiesel said, what are the most common patient concerns when we are prescribing local estrogens? Breast cancer, endometrial safety, and systemic absorption. If it's an estrogen, it's an estrogen. We need to answer with evidence. And the evidence says that the low doses vaginal estrogen produce minimal systemic absorption or null, generally demonstrate a favorable safety profile, and in fact, we don't need to use progestogens in addition progestogens. In other words, fear is there, but the risks are very, very, very low. As I said here, fear frequently exceeds actual risks, speaking about local estrogens. I am not going to speak about this because Kiesel, they put beautiful papers about what we can do about GSM in breast cancer survivors. Short decision making is essential. This is my point. It could be a second option. And for me, avoid therapeutic nihilism is fundamental here. You can, well, you have the possibility to use other treatments. This is okay, but if no, local issuing could be, but you need to speak with the patient and to take one decision. And the leisure, I agree absolutely with Professor Kiesel. With the guidelines. We need to use cautiously and selectively until stronger evidence emerges. You can use, yes. And it's effective, yes. But we have no, the data that we have with the local issuings. The gold standard are local issuing with no doubt. But occasionally you can use local measure. Move on for the last 2 or 3 slides. What is the forgotten problem? The adherence. Always, when we speak about a chronic and progressive disorder, the problem is there, the adherence. Why women stop treatments? This we need to analyze and to try to avoid. Because they feel that they are better, why no? Misconception about safety. They don't understand that they can use forever with no problems. You need to explain in detail. Cost, but the cost here is one of the cheaper instruments that we have. Lack of follow-up, maybe they don't know what to do. They need to be in contact with the doctor. This is absolutely agree. And the practical solution for me is to explain the first day that this is a chronic disorder, that they need to use local estrogen or some treatments for long term. You need to follow up the patient. Of course, you need to follow up and to speak with her and to explain everything. If you explain in the first visit, sure that you are going to have beautiful result. Because here, this is like, dear friends, you know very well, the majority of you, adherence is a real world problem when we are speaking about GSM. This is our problem. For this, I think that we need to be proactive. We need to explain in detail. We need to individualize treatments, follow up longitudinally, and women, we need to see if the women understand what the problem is. And of course, to open discussion of sexuality too. All of these points are in our hands, but sure that we need to have some time for this explanation. Of course, we need to have some time for doing it. The future perspective, they are fantastic, the future perspective. They are coming emerging areas, microbiome research, microbiome everywhere, regenerative approaches, combination therapy that they are okay. For example, you use laser, you need to use something after. Precision menopause medicine, you need to individualize. And digital health and symptom monitoring that perhaps in the future we are going to have a good role here. My point, the future goal for me is we need to move from symptoms control to restoration of genitourinary health and well-being. This is different. We need to cover more than only to control the symptoms. This is the issue for me. And finally, here, this is the last slide of this presentation. My key conclusions are GSM is common. chronic and progressive, no doubt. This is our challenge. Symptoms affect quality of life profoundly. Yes, it's not something minor, it's something important. Many women remain untreated. This is, again, something that we need to avoid. Early diagnosis and individualized therapy are essential. Local therapies are highly effective in real practice, and long-term follow-up improves adherence and outcomes. This is our role here. We need to explain that don't worry, we are going to be there, and this is going to be, I am going to follow up you for so many years. The final measures of GSM care is not only about tissue, it's about preserving quality of life, intimacy, and healthy aging. That means that this is something more important than only to improve some symptoms, I say. And thank you very much.
Mm-hmm. Thank you very much for an excellent presentation, Professor Palacios. Now we have received many questions, and I would like to start with a basic one, but very important one. What are the diagnostic criteria for GSM? And how would you deal with a woman who shows signs but no symptoms? Who would like to start?
I don't know, but I believe in the prevention.
Please start.
Yeah, I understand this question because the point is, if more than 50% of the women they are going to suffer GSM, why don't prevent in advance? This is something that the question for me is not sure that they are going to have any symptoms, any physiopathological change in the vulva and the vagina, but probably if you speak with the women and the women is open, why not?
What do you say, Ludwig?
Well, I think GSM is not something which suddenly occurs. It is a gradual change. So it may be that if you are an experienced gynecologist, you already see changes from normal before actually patients suffer severe symptoms. So symptoms can be very different. And I've shown to you the list of signs, but also the symptoms. And they don't go always in parallel. That's very common in other things. So I think that's what Dr. Palacios said. You may actually, if you see signs, you could actually do the treatment even before patients have severe symptoms. Often, actually, if you ask them, then suddenly it turns out that there are maybe some symptoms, but they wouldn't think it's something unusual because of aging, etc. So I think there is no limit to that, but signs and symptoms can be not all in one person. So you can look in the guidelines. They have all the lists of signs and symptoms.
I think actually several studies have shown that there is no clear correlation between signs and symptoms. So this could really vary. And of course, the symptoms are the most important. But in some cases, I think you are right that maybe the woman has not been thinking about this, but if you ask her, then she realizes. So this is very important. And then there are several questions about vaginal estrogen in women with risk factors for thrombosis. So this is about if there are contraindications. Who would like to start to comment on this?
Well, the same that I remember, I'm going to explain in one example. I remember that using 10 micrograms of estradiol 2 times per week during 1 year by vaginal route, the estradiol that all of us we know, the 10 micrograms of estradiol tablets, is the same that taking one milligram of estradiol by oral route per year. That means this is ridiculous. You can use always because you are not going to have any problem because the doses and the absorption is ridiculous.
Ludwig, would you like to?
Yeah, I think the data actually supports that, and this because the resorption has been measured. So interestingly, the resorption actually even changes because of the change of the vaginal wall after you're using estradiol. So sometimes actually it can actually even decrease, even lower than you would expect. So I think the level is so low that you will not even as the studies I've shown you, even for breast cancer, let's say in the German guideline, you can use actually in women estrogen receptor positive with aromatase inhibitors. They have severe symptoms, and it has been shown, as I demonstrated with the slides, that you can use it there. And the other questions were on thrombophilia. I'm not aware of any signs or any studies showing any change of the risk of thrombophilia because of the extremely low estrogen levels.
Exactly.
So that's for sure that risk factors for thrombosis are not any contraindication for vaginal estrogen. But then it's very, very upsetting, I think, that you have it in the patient leaflet. That it's written all these risks and including thrombosis. So this is a challenge when you speak to your patient.
We need to remove black box too.
Yeah.
I think this is a very, very long standing problem that there's so much things listed. Almost anything you can get in life is actually listed there, just to make sure for medical legal reasons that you have told patients. Because of course, with age, when you're using this, the risk for many of these problems increase with or without any other treatment. So the likelihood, even in breast cancer, of course, there is a certain number of patients who will get recurrence even without using anything else. So it is a difficult thing, and of course, you have difficult risk factors. Even breast cancer is not the same as another breast cancer, so it's very difficult to compare sometimes. But the risk is actually regarded as minimal for any risk factor. So long-term use, which is a question, can be done without harm.
One of our colleagues, they say that the package insert can pose a medical legal issues for clinical providers. This is true. And we need to try to change this one.
Okay, another question. Can vaginal estrogen be used in women after the age of 35 to prevent perimenopausal GSM symptoms and help preserve urogenital tissue quality? I mean, in young women. What do you think?
Well, there are two parts. One is, if they can use, of course they can use. But the question is, they need to use, this is other thing. Why? Because maybe if they are producing estradiol for themselves, they don't need it. That means that probably the answer is, perhaps there are going to be some cases where you can think about to use the local estrogen, but not usually because they don't need, because their own production is enough.
But maybe during lactation, what do you think? Could it be used during lactation?
For example, yeah, this is a good question. This is one of the area, the lactation. Other is the oral contraceptives that time to time they can produce locally some dryness. This could be, and we recommend a lot of time not only local estrogen lubricants for in this way. That means that probably there are some cases, yeah. Because if you say, well, the absorption, as we said before, this is ridiculous, this is very low, and they can use with no problem. And we are speaking about, for example, estradiol and estriol. They are natural products that the body, they know. They are not something strange. Yeah, for me, in some cases, you can use with confidence.
Ludwig, would you like to?
So I wasn't sure about the question. Maybe some part of the question relates to women with premature ovarian insufficiency at the age of 35. Now they are regarded as the same as with postmenopausal. You actually need to use it because that will have an even longer time experience. But in general, the population, I probably it will not do any harm. But it's I think the low effect in women who are regularly cycling and things, the effect may be very little. So there may be no need.
Here I have a special question. If a client notices very good benefits from applying low-dose estriol cream daily on her vulva against burning and itching, are there any hazards in letting her continue applying estriol cream on her vulva daily? What do you
Professor Kiesel, could you be the first and then going to the second in this case?
Well, I often say that actually the use of a cream has the advantage that you can actually individualize the treatment. And often women have not just vaginal atrophy, but they have often problems in the vulva. That's a very common thing. So I think I usually tell them to do this. Now, in our country, we have a sort of a dosage with twice weekly. That's in general. So you can do the same with using for the vulva. I'm not aware about using it on a daily term, but I think there are studies in the early days where it has been done. And we in Europe we are using more often estriol, but there are also estradiol creams, so which is usually more potent, but in general. But I would not be very worried, and I personally think we don't know how patients actually apply and how often they do. So some patients do only half the amount doctors say because then the risk is half. But that's more of a joke. But that's common. But some others do the opposite. They say, "Oh, I need more," and that can be the case. I mean, this is a big range of variety of symptoms. So I think I wouldn't be very worried. Maybe for a short term and not excessive amount. That's the other thing.
For me, this open a beautiful area. This is one thing is the vagina is mucous. Other thing with the epithelium keratinized epithelium in the vulva. And you need to treat both, of course. In fact, I train with local estrogens. I prescribe one specific moisturizer with growth factors for vulva and one lubricant when they have intercourse. That means that I prescribe three things. Yes, I prescribe three things in the GSM. Yeah, of course. That means that vulva is an enormous area. As Ludwig said before, we need to know more about, for example, the local testosterone in this area. This could be very nice to know in the future. We used so many years ago, for lichen sclerosis, if you remember, 25 years ago, the local testosterone. But well, I think that, yes, I use local moisturizer for vulva and local estrogen for vagina, mucosa and epithelium.
But you are not afraid when a woman is using a local estriol every day for vulva?
Well, no, well, I am not concerned in this way, but I don't recommend because we have exactly very clear treatment for it that is 2 times per week. That they don't need to use more. Other point is that if they can use 10 days every day, but only for 10 days for a short period of time. Of course, I agree with this, but not forever. No, I don't like it. I prefer to recommend not to use every day forever.
Okay. And then I can ask you this question. Do you use vaginal preparations containing hyaluronic acid in your clinical practice?
These are the moisturizers. There are
Yeah.
so many moisturizers, of course. Time to time, I combine 2 times per week, for example, local estrogen, and 2 times per week to some other moisturizer. In other occasions, when the women they don't like to use local estrogen, I recommend good moisturizer because now we have beautiful moisturizer with hyaluronic acid and with better hyaluronic acid. Of course, the hyaluronic acid, they are welcome. Probably the question could be that now there are some hyaluronic acid injections. If we use injections for with hyaluronic acid, and I use time to time. It's more expensive. That means that I need to have several reasons for using the injection with hyaluronic acid.
And you, Ludwig, would you like to comment on?
We do it sometimes, but I'm not very experienced with the use of it.
So I think we have time for a last question, and this is a question about the second or third line of treatment. What would you choose, DHEA or estrogen modulators, SERMs, for instance?
Well, I love ospemifene SERMs. Why I love? Because it's something simple, oral route, 1 tablet. And time to time, we need to remember that put something inside to the vagina is not very easy in some women, for example, in obese women with obesity, sorry, and or maybe with some problems, Parkinson, for example, or some diseases. It's not very easy to put something inside. That means that SERMs, for me, this is ospemifene. This is a very good option. We have already in my country, we use a lot ospemifene, and I love, and the result, they are very similar to the local estrogens. That means that SERM I use a lot.
But then they have to take it daily, right?
Yeah, this is true. This is true. They can use daily, and the DHEA exactly you can use to progesterone by every day. This is exactly the point. But the DHEA, the problem is that you need to use daily. This is true in comparison to 2 times per week, as for example, local estradiol or estriol. And the ospemifene, the good point is the oral route, but you need to use every day.
Actually, we had just published an article in Maturitas where we have randomized vaginal estrogen with DHEA, local DHEA, and with the same regimen. And it was shown that local DHEA was effective if you treat it twice a week also.
We spoke with the company several times in the past, and they say, no, the
Of course
trials are
not.
with every day. But now with this paper, maybe we can try to do
Yeah,
this. Is
it works. It
very
works.
nice. Very nice.
Ludwig, would you like to say a
Yeah, I have a
comment?
similar view. Yeah, a similar view on these second, third line, except that in my country, even we did studies with ospemifene, it has been not on the market. So maybe lack of using, I don't know really the reason for that. But that's the only reason what I would comment on the lack of use because of the availability. But I think it was regarded as a good treatment.
So we have come to the end, and I would like to first thank the speakers for excellent presentations, and also the audience for many, many questions. Unfortunately, we didn't have time to go through all of them, but thank you so very much, and I hope to see you soon again. Bye-bye.
Thank you.
Bye.
Bye-bye.
Bye.